This slide illustrates the normal anatomy of the great saphenous vein. It's usually encompassed in a fascial boundary. We can see this bright white line here, which is fascia, and this white line underneath it, so it's sort of wrapped here. And if you look at this, it kind of looks like a little eyeball looking at us here. Here's the eye staring at us, and here's the eyelids. That is the normal planar arrangement of the great saphenous vein. However, there are numerous tributaries, secondary branches, that will move up and out of this plane. They can have venous insufficiency and need treatment as well. So it's important to identify tributaries versus the main trunk, and the main trunk usually lies in this fascial plane. The other thing I note here is vein diameter. In this case, it's 7.4 millimeters. This used to be important in determining the size of catheters that some physicians use for ablation procedures. However, it's not quite as important, but some insurance companies want that information. So you may still be required to measure vein diameter in the superficial system if people are undergoing ablation techniques, which we'll talk about in a minute. Here is just another example. Again, we're angled in on this very kind of flat segment of the great saphenous vein. We've got our gain up a little bit so we can try to see low flow. And you just have to be careful that you don't overgain too much and confuse what the real signal is versus what the overgain signal is. Now, in many examples, I've put in the angle correct feature on the equipment, even though it's a venous study. And basically, we don't care about the absolute velocities, we care about the direction. However, this really promotes us to use a good angle. If we see it, we try to keep to 60 degrees, because if we get too far off 60, we're just going to decrease the Doppler signal so significantly that it'll make our job a lot harder. In this example here, I've turned the angle off so you can see we don't have an angle correction, but if we were getting too far off 60, we would not be able to pick up this signal as well as we are here. Okay, what about perforators? Well, perforators are small veins that connect the deep and superficial systems. Sometimes they directly communicate with the deep systems, such as the popliteal perineals, posterior tibs, or femoral vein. They're a straight shot through to those named veins. And sometimes they're actually just vessels that connect into various muscular tributaries or even the soleal veins. But they all have valves, and they all have, should have flow only in one direction. This slide shows some common locations for perforating veins, usually in the middle thigh, upper calf, lower calf. Some are branches straight off the main trunk of the great or small saphenous, and sometimes the perforators come off of branches, so there's a lot of variability. Clinically, in patients with ulcers, we see usually 3 to 5 that are relevant in those patients. This slide here is just taken from an anatomy textbook showing, again, the level. They all have names. These are the Dodds perforators, the Boyd perforator right around just below the knee. The Cockett's perforators are very important in the lower calf. They all have names. It might be nice to know the names. It's much more important to know where they're at and if they're working well or not. We're going to use ultrasound to identify the perforators in one of two ways. We're either going to follow the great saphenous or the small saphenous and look for branches that trail down and away deep in the image, or we're going to look at the deep veins and look for branches that come up and connect into the superficial system. We'll use color imaging or spectral Doppler again to determine flow direction. We can use some compression techniques to augment flow back and forth, and we'll want to look for flow in the wrong direction again that lasts more than half a second. Here we have a good color image of a perforating vein here. We don't really see the great saphenous too well because we're sort of off plane, but we can see the pathway of this perforating vein, and it's color coded in blue, so we know flow is going away from us, as compared to this vessel, which is color coded in red, and it's coming up. The flow is coming up towards this great saphenous sitting up here. So this is retrograde flow, and this is an incompetent perforator. We have to be careful because the perforating veins do have a small companion artery, and you can see that flashing at times, and it might confuse you. But again, the veins usually have a lower flow states, more continuous color appearance to them. Many of us also choose to measure the diameter of the perforator. We usually try to measure that about where it cuts through the fascia. Sometimes some physicians will elect to ligate perforators based on size, even if we can't determine insufficiency by ultrasound. In this example, this calf perforator is almost 4 millimeters, so it's likely to be incompetent. When we're evaluating perforators, if someone's going to have a perforator ligation, we'll mark the skin right where the perforator penetrates the fascia. As I said, we also record the diameter, and we'll make a note if there's a lot of wandering going around or if the vein comes off obliquely. Those things are important, again, when we're planning interventions such as a ligation or a vein ablation procedure. This paper was almost 10 years old, but published in JVS several years ago, and talked about, again, the size of the perforator, that once you get up 3.5 or close to 4 millimeters in the calf, that vein is likely to be incompetent, even if you can't generate incompetence on ultrasound. And once we get above 4, close to 5 millimeters in the thigh, that vein is incompetent as well. Now, during ablation, what are we going to do differently? Well, we're going to mark the great saphenous vein on the skin as an access site for entry into the vein, usually in the lower thigh or knee or upper calf area. And using our ultrasound, we're going to guide the insertion of the guide wire and the devices into the saphenous vein. We try to get a little bit away from the saphenofemoral junction because we want to leave the superficial epigastric vein intact. In this slide, we can see that tumescent anesthesia has been injected. We can see the very echolucent area of the fluid, kind of looking like edema. It does two things. It first acts as anesthesia, and then secondly, also acts as a heat sink to prevent any damage from the skin. We can see as well here that the catheter is in place in the saphenous vein, and this fluid has actually compressed the vein around the catheter. After we've done ablation, folks usually follow their patients. Certainly an early post-procedure ultrasound evaluation is essential to rule out the presence of venous thrombosis in the deep system. Some folks just do that one scan and never follow the patients again. Other folks choose to serially monitor their patients. That's going to be a matter of departmental policy. What we want to see is post-ablation, that there's echogenic material within the vein, that there's no color flow within the vein, and over time this vein will become atretic and shrink down and basically look like a fibrous cord, and in some individuals we may not be able to detect it. Here is an image of a vein that's post-ablation. This has all been ablated. It's fibrotic, not thrombotic. They don't like us to use that word. Following an ablation procedure, we can see the common femoral vein here and a little bit of flow still through that saphenofemoral junction, which is essentially coming through the superficial epigastric vein. This is what we don't want to see. We don't want to see thrombus here extending down through the saphenofemoral junction. This is obviously a potential problem for embolic disease and pulmonary embolism. This image shows a very, very thin fibrous cord where we can barely make out what was the great saphenous vein post-vein ablation treatment. So to conclude, venous ultrasound is certainly a very good tool to evaluate patients for venous insufficiency. Spectral Doppler will rapidly identify venous reflux. We're going to use criteria of greater than ½ second to indicate that valvular insufficiency. Color is a great tool. It rapidly identifies the direction of flow. If we're dealing with perforators, we may want to mark on the skin where the perforator penetrates the fascia to aid in the treatment of these perforators. And we're not only going to use ultrasound to diagnose venous insufficiency, but we're also going to use ultrasound during treatment treatment procedures such as vein ablation, and also to assess status post-procedure. Thank you very much.